All right, well, it's 7 o'clock, so we're going to get started. Good evening, everyone, and a warm welcome to our first webinar in the new series, Skin Cancer in You, presented by AMET Skin Cancer. My name is Krista Rubin, and I'm a nurse practitioner in the Center for Melanoma at Mass General Cancer Center in Boston, as well as your Ask a Skin Cancer nurse for AMET Skin Cancer. For those of you who are joining the webinar and are not familiar with our foundation, AMET Skin Cancer is a foundation dedicated to raising awareness and providing support to those affected by skin cancer. It's an honor to navigate you through this enlightening series that we have, which is we've designed to explore a comprehensive array of topics surrounding skin cancer treatments, management, and the emotional health for those affected by skin cancer as well. So this evening, I am thrilled to introduce Dr. Soo Park. Dr. Park is a distinguished board-certified medical oncologist and cancer researcher from the University of California, San Diego. Dr. Park will shed light on the critical role of multidisciplinary care in the treatment of skin cancer. So a warm welcome to you, Dr. Park. Thank you for joining me tonight.
Thank you so much, Krista, for having me.
Great that you're here. So let's start by talking about what multidisciplinary means. What is that term, multidisciplinary?
Yeah, so nowadays there's not just one way to treat cancer, especially with all the new treatments that we have from all the great research we're doing. And so multidisciplinary really means having physicians from different specialties come together to make a treatment plan for you that's individualized to the patient.
And so we're hearing so much about this, particularly in cancer care. Is this new? I mean, I've been in medicine for a long time, or in nursing, and multidisciplinary wasn't a thing when I first started. So can you talk a little bit about the evolution of multidisciplinary care and why we're hearing so much about it now?
Yeah, no, that's a great question. I think it's actually been around for some time, but probably only in select specialties where certain cancers historically have always utilized surgery and perhaps radiation and some type of IV treatment. But as we've gotten more drugs approved and we know how to treat cancer better and really help patients live longer, we've been able to really, bring multidisciplinary care into nearly every cancer field. And so it's somewhat new, but not totally new.
Yeah, so maybe the term, maybe we put a label to it where we didn't have a label before, but it is kind of the buzzword right now. And at my institution, we have a multidisciplinary care team approach, which I've come to rely on because, I'm not smart enough to be able to sometimes do what it takes to really take care of a patient comprehensively. So it's great to have colleagues to be able to rely on. So let's talk a little bit about who those folks are. Tell me about who makes up a multidisciplinary team. Who could I expect would always be on the team, and then perhaps who may be on the team? Let's talk a little bit about that.
Yeah, so usually the core team typically consists of a medical oncologist, typically a surgeon, typically a radiation oncologist, depending on the cancer. Pathology is really important because they help us really look at, a patient's tumor under the microscope. In some instances, we will also have genetic counselors come join us, nursing, social work, pharmacy, nutritionists, the whole 9 yards, because each person plays a really big part in the patient's care.
Yeah, that's a great point too. And you mentioned the pathologist. Could you maybe just explain what a pathologist is for those that may not be familiar with that role?
Yeah, so a pathologist is a special type of physician who's had training in looking at tissues, including cancer tissues. So anytime that a patient gets a biopsy, we take a piece of that tumor tissue through the biopsy, and the pathologist looks at it under the microscope and is able to tell us what type of cancer it is and what type of features the cancer has to really give us more information.
Yeah, that's really important too, because that's sometimes people wonder why biopsies take so long. And it's because they need to be assured that they're getting the right diagnosis to be able to make recommendations for the right treatment. All right, so let's talk a little bit about your institution, walk me through what a patient may experience if they see you at University of California, San Diego. What would that experience be like?
Yeah, so a lot of the patients that I see either get referred to me directly or we discuss them at our multidisciplinary tumor board. And that's a setting where, not only do medical oncologists like myself attend, but we have, like I mentioned before, radiation doctors, head and neck cancer surgeons, pathology, radiology, because for skin cancer, especially ones that occur on the head and neck, radiology is really important so we can get a better look at the tumor and see what's going on. And so we typically talk about the patient and preemptively come up with a plan. And then when I meet them, sometimes I make changes to the plan depending on what I learn about the patient and their individual goals, or, if there are any barriers that they may experience. Sometimes when patients just come to see me first, I try to get everything in line so I can talk to the other physicians in a multidisciplinary fashion, so then we can make a collective plan for the patient.
Just writing down a couple of notes that I want to come back to after. So a couple of words that you utilized, I want to just make sure that's clear. So you mentioned radiologist, and just for those not familiar with that term, a radiologist is somebody, a physician that reviews the radiology or images, so X-rays, CAT scans, MRIs, that type of thing. And that's important, an important person on the team as well, because that will help determine where the cancer may have spread, if it's spread, or if there are any other unusual features that maybe need to be considered. Agree with what I just said? Do you have anything to add to that explanation?
Oh, totally agree. They're super important in all tumor boards and all multidisciplinary care.
And so the other person that you mentioned on the team that I think is worth an explanation is the genetic counselor. Talk a little bit about that role on a multidisciplinary team, because that may be somebody that most people probably haven't heard of.
So genetic counselors are individuals that have special training in learning what different genetic defects may mean for a certain individual. There are certain diseases that are more prevalent in certain patients if they have a family history. And sometimes that means there's a genetic or a family history component attached to it. This isn't as big of an issue for some of the patients I see with non-melanoma skin cancer, although for some patients with a non-melanoma skin cancer called basal cell, there is a genetic component to it in some patients. But for melanoma or for other cancers like breast cancer, genetic counselors can be really important to inform the patient of, where the cancer might have come from, what risk they have from the cancer, and if they can potentially, pass it on to any of their, children.
It's interesting. And I'm glad you pointed out that it's not something that somebody with most forms of skin cancer would interact with for the most part. Other cancers, the genetic counselor may apply, but there are so many behind the scenes individuals on a multidisciplinary team. It truly is multidisciplinary in the sense of every discipline has a role in taking care of patients that have been affected by cancer and or their family members, which are also important members of the multidisciplinary team. So let's talk about what the patient's role would be. Does a patient have a role on the multidisciplinary team? I think I'd like to hear your perspective on that.
Yeah, no, the patient is an active participant along with us. We really want them engaged in their care because we want to make a decision that not only we feel is best in terms of, treatment outcomes, but we want to make sure that we honor what the patient wants, understand their expectations so that our goals align. Quality of life is really important to many of our patients, and we want to make sure we preserve that as much as possible with any of the treatments or procedures that we're recommending.
Yeah, that's a great point. We could almost do a webinar alone on quality of life and actually a lot of the other things that you've mentioned. So one word that I also wrote down was barriers. You talked about identification of any barriers to care when the multidisciplinary team meets. Talk a little bit about that for me. I bet participants would be curious to hear what's considered a barrier and what do you mean by that?
So, barriers can exist in different forms. Sometimes patients have trouble even just seeing us in the clinic because they have transportation issues. That's one barrier. Sometimes when you have lots of different physicians involved in your care, it can get really confusing. And so just being able to
Mhm.
coordinate care, that can sometimes be a barrier for a lot of patients. And, I'm also a patient myself, and whenever I have to access the medical system, it's so very complex. And so I can only imagine what it is like for our patients to go through that. There are other barriers such as, insurance hurdles, getting things scheduled. So we really try to make sure everyone is on our team to really help the patient.
Yeah, that's a good point. It is a lot to navigate a system, especially if you're just perhaps reeling from the diagnosis that you've just been informed about. So it definitely is a lot. So along that note, in your role as a medical oncologist, many patients are undergoing systemic therapy, meaning whole body therapy, like intravenous medication, some of these newer immunotherapies. And generally, the medical oncologist, or often the medical oncologist, will direct the care. So, how do you interact with other members of the team if you're kind of the quarterback, so to speak? How does it work behind the scenes, or what would it look like when there are time points where decisions need to be made about what's next?
Yeah, so that's one of the reasons I really love being a medical oncologist because I am oftentimes the quarterback in a patient's
Mhm.
care, and I learn, a lot about that patient and can follow them longitudinally. So when we come to a point where I need, the expertise of one of my colleagues, because I'm in an academic medical center, it's really easy for me just to reach out to them and, sometimes I can just run up to their office because we're in the same building and really, inform them and update them of what's been going on with the patient, what I've done up to this time, why I'm asking for their opinion on something. And then we are able to make a collective decision about what we need to do next and then let the patient know. So in that way, multidisciplinary care is very seamless and it occurs at multiple stages of the patient's journey.
That's a good point. Now, you mentioned an academic medical center. We're both at academic medical centers. What's your experience been like with non-academic medical centers and multidisciplinary care? I mean, is this something that somebody could have access to in their local community hospital? Talk a little bit about that for me.
Yeah, I think, the COVID pandemic changed a lot of how we practice medicine, and it has increased accessibility. Now we can do virtual visits, and that platform also extends to things like tumor board or reaching out to physicians, even having new patients see us. So, academic medical centers typically, utilize multidisciplinary care and tumor boards more often than community centers, but I've seen many community centers have their own tumor board and they're very robust. And sometimes they do reach out to us because we're the ones that typically have a clinical trial, or perhaps we, have a physician that has a certain expertise or the patient needs a higher level of care. But, virtual platforms have made it really easy to, communicate care about a patient across, physicians, across, cities and different hospital systems. So it's been really great.
Yeah, so as awful as the pandemic was, there were many very positive things that came out of that, one being kind of the more established virtual access to healthcare, which is really opening doors for individuals that may not be close to an academic medical center. So in your experience, have you had patients request a multidisciplinary approach? Is that something that patients can ask for? If you've newly been diagnosed with, say, a complicated squamous cell carcinoma, for example, should they be requesting a multidisciplinary approach to their care?
I think so because nowadays, in the past 2, 3 years, we've had lots of really exciting treatment advances in the treatment of non-melanoma skin cancer, such as cutaneous squamous cell carcinoma, that I do feel like a multidisciplinary, care is advised because you never know, what a different team member might recommend and how that might alter your treatment trajectory, and it might actually in turn be better for you. And, we all learn from each other day to day. And so it is your right to request a multidisciplinary review. And it's something I would encourage as an active participant in your own care.
Yeah, that's great. That's so empowering for patients to hear because it's their health, it's their care, and they should be partners. And so, not being shy, advocating for oneself or a family member, is only to the advantage of that individual. So, I appreciate your comments on that. So, let's talk about tumor boards. That's a scary sounding. Set of two words, tumor board. What does that mean? What does that look like? What is a tumor board?
Yeah, I really think it should be renamed. It's so archaic and it doesn't really reflect what we actually do. But tumor board is just a very old term that needs to be changed that just basically means a multidisciplinary care discussion. And so that's when we all get together, the medical oncologist, the radiologist, the pathologist, the surgeons, the radiation oncologist, nursing, social work, et cetera. And we talk about, each patient, especially ones that, may need more complex treatment or, may need treatment from every single individual on the team. And so we just present their case and discuss, what's going on, what we think we need to do. And we always come up with a individualized treatment plan at the end. And sometimes, that may include things that we didn't think of. There may be a clinical trial or a new way of doing something that the radiation doctor has recommended to us that we then incorporate into the care plan if we feel like it's appropriate. And so that way we're able to really, tailor care and advance it for the patient.
Yeah, tailor and care, that is key words because everybody is different and every single cancer is different. And so one size does not fit all when it comes to cancer care. There are guidelines, but certainly individualized care will only increase successes. So a couple questions I've thought of along the way too is many patients, if not most patients, are diagnosed with a skin cancer at the dermatologist because they go in, something's found on the skin, a biopsy is done, and alas, a diagnosis of skin cancer. What's the role of the dermatologist in the multidisciplinary team? Because often they make the diagnosis, but then a patient is sent to other providers. So is there a role for the dermatologist on the team?
Yeah, absolutely. Dermatologists are also really key. Anytime a patient has a skin cancer, they are at increased risk of getting a second skin cancer. And so it's really important for that patient to really, be under the care of a dermatologist and be closely followed by their primary care doctor just to make sure that they get skin checks every so often. Because if you're at increased risk of getting another skin cancer, that other skin cancer is best managed when it's found early and we can just, the dermatologist can get rid of it. As opposed to, if we didn't find it until at a later stage and then, it becomes more difficult to manage. So we partner with dermatologists all the time. I try to make sure that every one of my patients is, has established care with a dermatologist.
That's a great point. Great point. Yeah, we need our dermatologist on the team. So in your opinion, are there any disadvantages to a multidisciplinary care approach?
No, I actually don't think so because, cancer care is becoming increasingly complex every day. We have new treatments every day. And so I think, really being able to learn from each other to really provide the best care to the patient, because ultimately what we want to do is we really want to improve outcomes and we want to meet the patient's goals. So
Mhm.
in the end, I think there are no disadvantages.
Hmm. One of the things I appreciate most is working with a multidisciplinary team as many of the patients that have been diagnosed with an advanced skin cancer are often more, I don't want to say older, but they're often, I like to use the term wiser. In other words, it's an older population of patients in the sense of skin cancer. One of the greatest risks is age. The longer you've been exposed to UV, ultraviolet, the greater risk you have of developing a skin cancer. So we often see individuals in their 70s, 80s, 90s, even a couple over the age of 100. And so having other specialists on the team has been really helpful when we think about other medical problems an individual may have with skin cancer. You're nodding your head. I can see that you're in agreement with that. So there are a lot of treatment decisions that have to factor in other medical conditions an individual may have, such as cardiac, or if an individual's had an organ transplant, that can be complicated. We often see a lot of patients with squamous cell after they've had an organ transplant later. So having multidisciplinary tumor boards and discussions has really been incredibly beneficial. I think to me personally, I've learned so much. It's intimidating to have a lot that you don't know, but being able to talk through with other disciplines has been really, really incredible. So anything else you want to add that maybe I didn't ask or we didn't talk about yet with regard to multidisciplinary teams?
No, I don't think so. I think we touched upon, everything that I agree everything with what you said.
Okay. All right. Then I'd like to switch gears and answer some audience questions, and please feel free to use the Q&A to send us any questions. We're happy to answer that. I'm going to take the first question here from Mike, and Mike asks, is it typical that a medical oncologist should be reading radiology reports such as MRIs, PET scans? For example, if there is spread of a cancer to another organ, is it generally the medical oncologist that would be reviewing, or is it the radiologist that would take the lead? Thanks for your question, Mike.
Yeah, so anytime a patient gets a scan, the care team, is able to, open that scan and take a look. And as a medical oncologist, I will often look at the scans of my patients, but I was not formally trained in radiology. And so while I can, give a very brief, rough interpretation, if there's a new mass or I see something that lights up that should not be there, I can interpret those, but every scan should formally be read by a board certified radiologist because they've had special training to really, read everything and find all the nuances that may really impact your cancer care. And so it's actually the radiologist that takes the lead, but we also have access to them, and we do routinely look at the scans of our own patients.
And I would imagine that is the best opportunity as a multidisciplinary team to talk through with that. It's helpful to give context often to the radiologist about what you may know about the patient that may influence or help interpret what may be seen on the scan. So I think that's a great example of collaboration with another discipline to make the right diagnosis. And often we see the same thing when it comes to pathologists. It's helpful for the pathologists who are reading the biopsies under the microscope. Sometimes if they have more information about what they may be looking at, they'll often come to a conclusion or a diagnosis faster. Would you agree with that?
Yeah, there's been so many times where, because radiologists are focused on reading images, they don't see patients in the clinic like we do. And so when we are looking at a patient's image, sometimes they will bring something up, and to us, because we see the patient, we can give them, like you said, the clinical context behind why, something may look a certain way, and that we're not that worried about it because maybe the patient recently had an infection, and that's why this area looks a little, like full or strange or whatnot. But, and they didn't know that. And if they hadn't known that, then they would have maybe interpreted the image in a different way. So that's why a multidisciplinary team is so powerful.
Yeah, that's a good point. So we talked a little bit earlier, we touched upon academic medical center versus community medical centers. Is there ever a case, or have you personally or know of, where you're collaborating, say, with the local oncologist? For example, a patient may come to you for a consultation, but lives 3 hours away, and it's just not necessarily practical or easy to get into to where you are in San Diego. So do you have an approach where perhaps you could manage a patient from a distance, or work collaboratively with a local oncologist to help manage care for an individual?
Yeah, so oftentimes, because at academic medical center, we have certain areas of expertise that we're really proud of. And I will often see patients for not a second opinion, but for collaborative care. And so I may see the patient once after I've reviewed all their records and really render an opinion that I've also been able to run by our multidisciplinary team, and really not only tell that to the patient, but also communicate this to the patient's other oncologists because maybe it's very hard for them to see me. Maybe they live 3 hours away, maybe transportation is a barrier. And then, oftentimes throughout that patient's journey, I'm able to, discuss the case in real time with that outside physician and to really collaboratively manage the patient. And that has, wins on both ends.
Yeah, that's great. It does certainly make it easier. But there are some cases where it really isn't feasible for an individual to be managed from far away. Often that has to do with the experience of the provider. You and I are in very specialized fields where we see only skin cancers, and not all members of the healthcare team focus on just one cancer like we do. I feel very privileged to be able to do that. But sometimes the oncologist, who is a more general oncologist, he or she may not have the depth of knowledge that those of us that do this every day do. So often we'll say to patients, as much as we want you to be able to go locally, we really, feel that there is a need or a reason for you to be seen at the academic center. And you're nodding your head because those are really hard conversations. We don't want people spending 6 hours a day in the car when they can be home doing fun things or with family. But sometimes in order to provide care and to provide the best care that we can to patients, we sometimes have to say, you got to come into town. All right, so we're coming on to the end of the half an hour here, which, gosh, that really went by very quickly. I love talking with you. We always have great conversations, and it seems like our practices are very similar. So I just want to say thank you to you for taking the time out of your day. It's just late afternoon for you in California. Your insights have been invaluable, and your dedications to patients and families certainly shines through. I thank you, and I would like to express my heartfelt thanks to the participants. Each of you took the time to join us this evening, and you're certainly committed to learning more about skin cancer, and that's quite commendable. And for those of you that want to read more about multidisciplinary care, please visit our website at ametskincancer.org for a new blog that's been posted on the topic, "There's No I in Team, a multidisciplinary approach to cancer care." And that blog certainly sheds some light and insights on multidisciplinary approach. And I'm being told we have another question to sneak in here. It looks like Tammy's asking about the care that she received at her local institution. I think what you're asking, is the team the same? And my answer would be that multidisciplinary boards are similar. It may vary from institution to institution, but for the most part, yes, I would say this similar members. And Dr. Park, do you see another question?
Yes. It says, where can I find guidelines or medical recommendations on how frequently I should have an exam by a dermatologist? The healthcare provider placed me on an annual exam schedule, even though they had a melanoma in situ removed and have other skin cancers. So the frequency of how often a dermatologist should examine your skin and for skin checks is really individualized based on your personal risk. Have you had a solid organ transplant? How many lesions have you had that have to be removed? Are you extremely fair-skinned and, very prone to sun damage? And so that's something that after your dermatologist does the full body skin exam, then your dermatologist will be able to tell you, based on my assessment, I think I need to see you every 3 months or every 6 months, or even just once a year after the initial assessment. And that's really based on what the dermatologist thinks your baseline risk is.
Yeah, that's a great. There certainly are standard guidelines, so to speak, for a diagnosis. The national, NCCN, it's called National Comprehensive Cancer Network, does have basic guidelines, but really those are just guidelines. And as Dr. Park mentioned, based on an individual's risk, which the NCCN would not know, that needs to be tailored to each person, each patient. So some people may need more frequent visits, some people may need less frequent visits. But that was a great question. All right, so it's 7:30. I want to respect everybody's time. I want to say again, thank you to Dr. Park. Really appreciate your time and your insights and your expertise. And to everyone, I wish you a good night. Thank you for being
All
here.
right, thank you, Krista.
Bye-bye.